Okay, so today's subject is really taking us into the first steps in the research cycle, in the health policy and systems research cycle, and we're going to be looking at what this cycle is, what the 8 steps are, from setting a priority, defining a problem, all the way through to thinking about an analysis plan. And then the second thing we're going to be doing is spending a bit of time thinking about how this exercise of priority setting is actually done. So the first thing I'll be doing is telling you a bit about the framework that we'll be using in this course for planning a research study and implementing it. The second bit will be to look at different ways that we can use to set priorities for health policy and systems research at different levels. And the third will be to give you some support in terms of understanding how to define your research problem. So research, I think what's very important to take away from this diagram is not a linear process. And by that I mean that we often start with some theory. Okay, you might say, no, I don't have a theory about what I'm looking at. But everybody has some hunch, some idea at the back of their mind about their topic, right? You don't go blindly into the field. The reason you choose a topic is often because there is already a sense that there is something that's not as it should be. There is some kind of problematic issue, or there is some gap, and you already have some sense of what you might find. So even if you don't think about it as a grand theory, you already, because you're human beings and because we're constantly interpreting situations around us, events, processes, we have some theoretical thinking that's inherent to us. And the theory leads you to pose questions or pose a hypothesis. Often in quantitative research, you are actually stating a hypothesis that can be proven or disproven. But the theory should lead you to questions, okay? So even yesterday when you did your frameworks of the health system, if you went back to those frameworks and you said, how would I ask questions that are derived from this framework, you should actually be able to do that already, okay? Even if they're not very fine or sophisticated, but you should be able to formulate questions based on what you outlined yesterday. From questions, we move to a research strategy. And that strategy usually involves thinking about a design, an overall methodological approach, and maybe a setting and a population. And then we move into the actual methodology, the methods of data collection, the way I'm going to conduct myself in the field. A lot of that is dependent on the type of research you're doing. And then you might have your analysis plan. But after you do some basic preliminary analysis of your data, it may actually lead you to revise your original theory, right? And then you might say, actually, I need to go out and do a bit more research. Okay, so in quantitative research, frequently you do not have that opportunity midway in the research to change or shift your questions. In qualitative research, it's very common because you're learning along the way. And so, you might collect some data and you might realize, oh, my questions could be refined, or I need to talk to an additional group of people, and so on. So this process is iterative. It's not linear. So when we think about the health policy and systems research process, we generally think about 8 steps. And here it looks a bit more linear than what we saw on in the other diagram. But it is just for the purposes of illustration to show you how we're actually structuring the content of this course. So today we're going into problem identification. And by the end of the day, you should have a good idea of what it means to define your research problem. And from that, to have a broad sense of the aim of your research, right? We will spend more time this afternoon and tomorrow framing the issue and formulating questions. What do I mean by framing the issue? What does it mean to frame a topic? What do you think it might mean? Yeah.
Identifying the research gap.
Mm-hmm.
Referring to the existing literature and identifying the research gap leading to formulating the research questions.
Okay, I would say that you're halfway right, but there's something else when I'm talking about framing, okay, which goes back to the role of theory that we saw in the previous diagram, okay? So what does framing mean? So why is it that, let's say we're looking at, again, going back to the TB control example, why is it that this gentleman here, who has experience in TB, is going to frame the problem differently from this table, where you might say, we don't really have experience in TB, but we're going to do some research. So you're going to frame the problem differently. Why is that?
Maybe to previous exposure, like we got this knowledge, attitude, and practice, like while framing forming a issue means writing a problem statement. In other words, you mentioned about TB, the guy has more exposure and he has got insights about TB, how it is working, at all the level, from clinical to implementation. Mm-hmm. So it will be very easy for that person, which problem we need to give priority more, or which one to be given the first priority, and which one supposed to make or take it as a question for the research, and where the gap, so it comes there. So that the difference in making or framing an issue from a person who is exposed to that any of the field is entirely different for the person who is not at all exposed to that field. That's what I meant.
Okay, good. So the issue, yes, go ahead.
As he has worked in that, he will be giving us an insider's perspective. Mm-hmm. And as a researcher or observant, we will be having an outsider's perspective.
Okay, very nice. Okay, so the main thing is, sorry, I'll just continue. The issue about framing is not so much that he is in a better position to do research, okay? It's not about better or worse. He is more exposed, he has more experience, but that might be a disadvantage. Why is it a disadvantage, potentially?
So, as the ones who don't have exposure, we...
Thank you. Okay, so as the ones who don't have experience, we would look at each and every angle, mm-hmm. And then decide in which direction we want to go, mm-hmm. regarding a particular issue. While he already knows the weaknesses and the strengths of the TB program, if you're talking about that. So he would naturally be directed towards those parts which he as
okay,
the person involved.
Okay, nice. Okay, so we'll continue along that vein, but the point is that always think about the sense in which your background, your training, your preconceptions are going to shape or frame the topic, and be aware of that, yeah? So if somebody is very well exposed to the TB control program and all the issues, the problems that it may throw up from a programmatic point of view, it means that he has to take extra care to make sure that he's explicit about his position and the way he's framing the topic, okay? Which may be quite different than yourself, okay? Because your starting point is different. You're going to say, I'm interested to understand why TB workers are not happy with their jobs, because why is TB undervalued or something as a area of work or whatever it is. Okay, but the starting points are different, but we'll get into that. Okay, so framing the issue, we then move into study design tomorrow, and then we'll be doing some work in terms of thinking about methods and methodologies at different levels of the health system, and then moving into some tips for analysis and interpretation of your data and knowledge transfer. So health policy and systems research has a very specific focus on policies and systems, but it actually borrows its methods and approaches, we've already said, from very different disciplines. And each discipline has a different way of doing research. So again, you can come at it from the point of view of your own personal work experience and think about the questions that the topic arises for you, but it also, you can come at it from different disciplinary perspectives. So I recently examined a thesis which was about the history of the DRTB program in South Africa, and this person took a historical perspective, trying to understand how the history of apartheid, the very racist policies of the apartheid government, how it impacted on labor migration patterns and in turn fueled the drug-resistant TB epidemic. So they were looking historically at what had happened and how the program was responding to those particular emerging challenges. Now that's a historical perspective, but if that person had been a geographer or an anthropologist, they might have started from a different interest, right? Researchers develop a shared understanding of the discipline, which is referred to as a paradigm, and a common way of doing research methods. So often, if we're trained in a certain discipline, we tend to work with a specific paradigm of research. So we're going to explain what paradigm means. But the structure of the research process is common. So it doesn't matter what paradigm you're using, but essentially you're still using these steps. So we're going to come back to the issue of paradigms, this I think a bit later, and I'll explain that a bit more. But let's start with how we identify the problem, okay? So this step is as much about the topic of investigation as it is about deciding what merits research. Because when you choose to do your research, whether you're a PhD student or a master's student, or whether you're somebody who's commissioned to do a piece of work, you want to ensure that what you're doing is actually valuable, that you're not replicating work. You're not doing something that has already been done. And so you're going to do a lot of background research to find a question that's novel, that's interesting, that's unique. Now, obviously, at a master's level, nobody's going to demand of you a novel contribution to theory. But still, for your own sake, you would like to have the sense that you're doing something that is valuable, relevant, and maybe a bit original in some ways, right? So this step includes usually a situation or a problem analysis, because you want to see this problem that I'm looking at, how can I understand it from my unique angle? So who decides which topics merit or need research? Yeah? Who makes that decision? You probably won't make that decision on your own if you're looking more broadly at a bigger project. But you might say, okay, let's look at the field and let's see who are the people who are setting the agenda. Are they policymakers? Are they technical people? Are they technocrats? So going back to the topic of the regimens, the drug regimens, it could be that the research agenda is being set by the pharmaceutical companies, right? Because they want to know and they want to get their drug as quickly as they can onto the market. So the agenda setting is happening from a very powerful lobby. Are they service or program managers? Okay, so if you're from a pharmaceutical company and you're from the program, you're a program manager, your starting point for the research will be different. Your timelines for the research will be different. What about politicians? What interests do they have in funding or commissioning pieces of research that are going to shed light on them favorably, right? Funders, okay? We know that in many parts of the world, the research agendas are very much dictated by donor funding priorities. And when the donor funders mix with politics, like we've seen under the US government, it has severe consequences for what gets funded or indeed what doesn't get funded at all. So at the moment, as you know, we're in this funding freeze from the US government donors. And this is unfortunate that this is all the way at the bottom, but the question of whether the beneficiaries, your clients or your citizens or the public, to what extent do they set the agenda? They should be setting the agenda because they're probably the people who are most responsive to the services or the interventions, and they should be benefiting the most. But very often they are kind of at the bottom of the list because they don't have the voice or the power or the authority to really articulate. So we pay some lip service to community engagement in research priority setting, but the reality is the research priorities are not generally, unfortunately, not really set at that level. We try to do it to some extent, or we look for ways to do it, but that's another topic. Okay, so the research priority setting process, which I'm going to describe a little bit, is really to ensure that the best use is made of available resources from an equity point of view. Health research is based on this idea of the value of equity, and therefore you need to employ a really systematic approach to setting priorities, because health is something that is considered a public commodity. It's a public good, and therefore the decisions that are taken about where I allocate funding for health research need to be taken in a fair manner, in a way that is, in a just manner, and so on. So we're talking here about health research more broadly, because there's a lot more information and research, or rather studies about how priorities in the health sector are set than in the health policy and service and systems research. So you have to think about identifying human and financial resources required, planning, amidst competing and overwhelming demands. The other aim is to strengthen the links between research, action, policy, and practice. And this priority setting really happens at different levels. It happens at a global level, it happens at a national level. Sometimes it happens within a specific discipline or within a specific institution. So the Department of Health Sciences here probably sits down and sets some priorities in terms of the research topics they want to pursue. And they may not have a lot of freedom there because they're very contingent on the funding that's available through ICMR or whatever. But they will still nonetheless make a decision based on the strengths, the expertise of the department, the interests about what they would like to pursue as a research agenda. So it's acknowledged to be a key function of national health research systems, and it's a very important process because you have to align your research funding with evidence needs. But priority setting, the reality is, for health research is often not really performed particularly well, and sometimes it's not performed at all. So the reality is, in many low and middle income countries, the research priority setting exercise was not particularly well developed for a very long time, until the mid-90s. So this is a quote from a study, and I should have provided you with the reference. But this is a study that was done by Kent Ranson back in 2010, I think, where he's citing a survey by the World Health Organization of more than 550 policymakers and almost 1,900 researchers in 13 low and middle income countries found that about a third of policymakers, researchers, and users of research interviewed said that there was no rational process to set health research priorities in their country, or that they were unaware of how those priorities were identified or set. So that's quite alarming. So there's actually the reference to that paper. It's Ranson-Bennett, Priority Setting in Health Policy and Systems Research. So thinking about health policy and systems research priorities, when it is a difficult field to situate within the general health research priority setting. Because when you're thinking about health research priorities, you're often thinking specifically about things like disease burden, right? How severe is it? What is the impact on the economy? What is the impact on people's livelihoods? Whereas health systems and policy research priorities are more about what is functioning or not functioning in the system. So we cannot really use the same principles that we use for setting health research priorities for health policy and systems research priorities. Because if we do that, for example, if we look at health policy and systems research issues through a specific disease lens, for example, trying to establish priorities in malaria or HIV or NCDs, the priority exercise becomes more technical versus interpretive in nature. It's driven by the disease burden and often focused on understanding how high that burden of disease is and how it can be averted by developing new drugs and technologies or improving whatever we have or extending the uptake of existing interventions. So these 2 points definitely are not about health policy and systems research, right? They're about changing drug, as we spoke about this morning, about changing drug regimens or coming up with new drug regimens. Extending the uptake of existing interventions could be implementation research, but otherwise that's it's quite limited. But on the other hand, when you think about a health policy or a systems research priority, sometimes when you're thinking about the system as a whole. So therefore, if you're trying to decide on priorities for malaria control, you have to think more broadly. How is this going to impact on the rest of the system? If I pour money into HIV, does it mean my other services in the system are going to be underfunded and less able to deliver their interventions, which is exactly what happened, right? In the years where there was so much money pumped into HIV that the rest of the system got weaker in many countries. So health systems research question may provide benefits or may have unintended negative consequences for multiple other diseases. So here the argument is that if you link health systems research questions only to specific diseases rather than seeing them in totality, it results in those topics being deprioritized, resulting in a kind of fragmentation of systems research. Okay, let's just look at the kinds of organizations that are doing health policy and systems research setting and that are trying to overcome the kind of challenges of using the sort of normative frameworks that are used for health research setting. So there is something called the Global Forum on Health Research, which was established in 1988. So this is actually for health research, but they have tried to take health policy and systems research more into account. And it's essentially demonstrating the essential role of research and innovation for health and health equity to benefit poor and marginalized populations. It's trying to facilitate the definition of global research priorities in health, which is a huge exercise, because as soon as you move into the global realm and you recognize also that setting priorities in one country without thinking about the country next door is also an issue, right? With globalization and cross-border movements, etc. It's trying to stimulate coherence between actors involved in health research, and it's trying to strengthen the use of evidence in decision-making. So these are some of the considerations that are relevant. We need to think about the way in which priorities can be set at a global, national, subnational, or institutional level. We also need to think about comprehensiveness. So some priority setting processes will focus on narrow questions. So for example, key research questions for malaria control. Others are going to set questions for the whole health sector, right? There is, I mentioned this word before, the technical versus the interpretive. Okay, you might say, what does that mean? What exactly did you mean by that? So processes within the health sector can be predominantly technical. So in other words, they're dominated by quantifiable needs or cost data, which is a technical approach to setting priorities. Or they can be more interpretive, which means I want to gather consensus, yeah, from a group of people who I consider experts. Okay, I'm going to bring together a group of people who have a good idea about what the priorities are, or what are the needs really before the priorities. What are the needs? What are the needs? What is the evidence for those needs? What is the evidence on the cost effectiveness of interventions for those addressing those needs? And I'm going to gain agreement or consensus. Okay, that's a different approach from a purely technical approach that just goes on cost data or cost effectiveness data. The fourth point is that who am I including in my group of people who are involved in the research priority setting process. So those included in a consultative process could be primarily researchers or experts in the field, or they could involve funders, research users, or communities. So this is also a very big decision. So if you consider each of these points, when you think about priority setting exercises, even at a small level, I think these are worth considering. Okay, what kind of evidence am I bringing into the equation? What kind of people am I going to consult, right? And am I looking at a more technical form of evidence, or am I looking at interpretive evidence? And at what level am I setting my priorities? So, yeah, I think we've said this one already. We've said that if we looked at HPSR through a disease-specific lens, we would result in a situation whereby we have a fragmentation of the health systems research, and what we really need to be doing in terms of HPSR priority setting is emphasizing health systems challenges. So back to the building blocks in some ways, the governance, the financing, the service delivery, and the roles of specific actors within the system. So this is another forum, which is called the Health Research Forum, which in the 90s produced what are called the 1090 reports, which was essentially stating that 10% of resources worldwide devoted to health research were put towards research on health in LMIC, whereas more than 90% of preventable deaths occur. So basically it was highlighting this huge imbalance in terms of where the resources for the research were going. And it's not so surprising, right? Because you can imagine those high cost, very highly technical, very high, biomedical types of interventions, very sophisticated interventions are also going to be the most costly in terms of research. Whereas research that involves low cost, acceptable, low tech interventions are going to be less expensive. But it's still a shocking fact that only 10% is spent in countries where you have 90% of mortality that you could be prevent. So as a result of this quite alarming report, there were efforts to develop more rigorous research priority processes in LMIC. And this forum intended to provide impartial evidence, practical tools, and intelligence for informed decision making. So this was happening around the 90s. It was also conducive to fostering some networks, coalitions, communities of practice, which would lead to solutions in terms of how we would go about this exercise, and really trying to advocate for changes in priorities, resources, and policies. So what was also happening in the 90s is attention was being drawn to the fact that the research priorities for low and middle income countries were mainly being drawn up in high income countries. And so there was a real imbalance in terms of not only the research priority setting process, but also in terms of the research that was being produced, and the imbalance in terms of low and middle income research produced in terms of publications and things like that, okay? So in 2010, this Global Forum on Health Research was absorbed by something called the Council for Health Research for Development, which unfortunately subsequently suspended its operations due to financial circumstances. So that's just to mention that if you look it up now, you'll see that it no longer exists, but there are some other organizations which continue to do these exercises. One that we've mentioned yesterday already is the Alliance for Health Policy and Systems Research, which was set up 1999 and hosted at WHO. And they also, although they're not explicitly a research priority setting agency, but because of their importance in the field of health policy and systems research, they tend to set the tone. They tend to commission small pieces of research, and they define topics of interest. So whenever you want to see what are kind of globally, what are some of the key health policy and systems research topics or the agenda, it's worth going onto their website and looking at, recent calls, recent reports, and so on. So they promote and generate the use of HPSR as a means to strengthen health systems in low and middle income countries. It's a unique forum for health policy and the systems research community. They're involved, I think, in hosting the health systems global meetings, which happen every 2 years, and which are a very important place to both, to gain more knowledge about this field, but also to network. They support institutional capacity for conduct and uptake of health policy and systems research, and certainly in the early years, they tried very strongly to set up South-South partnerships. So they would have researchers from Kenya coming to India and researchers from Uganda going to wherever other countries. So there was some stimulation of the idea that actually local researchers who were close to their health systems were in the best position to conduct some of this research. And they stimulated generation of knowledge and innovations to nurture learning in health systems, increasing the demand for and the use of knowledge for strengthening health systems. So these are some of the reports that came out of the Alliance. We've already mentioned the systems thinking report before. The one on the far left is the reader, which is freely available. As you know, you would have looked at the first chapter, and the whole book is actually, it's a reader that I participated in many years ago. I think it's 2012. And it offers not only a narrative account of different types of research that are contained within HPSR, but it also offers you very good examples of papers that use a particular research methodology and a particular framing. So these are some of the other examples. There was one on, oops, it's not working. That was one on human resources for health that was produced a few years later, one on medicines. This is a fairly recent one, I think, the participatory action research one in health systems. And that is a topic that we'll also be taking you through in the course of the lectures. Okay, let's move to national level priority setting processes. So before 2010, priority setting processes for HPSR relied on relatively limited consultative processes, which took primarily place at a global, at an international level. And after 2010, there was really emerged a strong rationale to use country priority setting processes to inform global priorities. So it was kind of seen in the other way, that actually national level and even further down should be informing the global rather than the other way around, right? And these approaches often combine expert input with stakeholder engagement. So these are some of the methods that have been used, which you may have heard of. And they're essentially methods that attempt to generate a consensus. And a consensus simply means agreement across a group of experts or stakeholders. Delphi method is one method. The nominal group technique, which involves structured small group discussions, where participants generate, they discuss, and they rank research priorities. But there's also been the attempt to include more participatory approaches, where policymakers, frontline health workers, and communities are engaged to identify pressing health systems challenges. Other interesting examples include things like citizens' juries. Okay, so a citizens' jury is almost like you know what a jury is, right? Where you bring in members of the public, citizens, to participate in legal decisions. A citizens' jury is a common, well, it's maybe not that common, but it's a form that is used in the UK. And for example, there was a deliberation some years ago about the use of patient records in research. And they had a citizens' jury where across the country they had stakeholder meetings with members of the public to debate this topic. And you might say, well, how do you involve members of the public in something that seems kind of technical, the use of patient records? But I think the whole point is that the whole process, the deliberative process that led to the inclusion of members of the public in this was a really important one in terms of empowering people to have a say. Crowdsourcing is another kind of thing. Crowdsourcing is often thought of more as a media thing, as a way to generate creative ideas, etc. but crowdsourcing can also be used to gather opinions on what people think is the most pressing thing that should be dealt with through research. Okay, so crowdsourcing happens a lot in Europe. I mean, I'm constantly getting things through the mail from the council of the city where I live, which is saying vote on the new design for the park near the train station, or vote on the new, it's usually around urban infrastructure, but it has been used also for things like ideas to improve accessibility of people to testing services for something, or screening services, and so on. Okay, so at national level, there is something called the Essential National Health Research Framework. And again, this is not specific to HPSR, but it is a national level framework. And that was developed by the council that I mentioned before. And they essentially rely on two different forms of knowledge to inform the research priority setting process. One is an evidence-based situation analysis. So in order to set priorities for the health sector, they would want evidence on health status. What are the main problems? What are the common diseases? What is a burden? What do they mean for people's morbidity, mortality, for their quality of life, etc. And they also collect information on the health system. So the current status, the current capacity, capabilities, deficiencies and problems, and the health research system, which I think is also an interesting point. So the capacity of the health system itself to engage and produce research. So is there capacity, is there funding, is there allocation, is there experience for people within the health system to be able to be reflective, to look at the data that is coming out of their system and analyze it? Because we know in many health systems that are underfunded, you have vast amounts of data and nobody actually gets a chance to look at it or make decisions based on that data. And so I remember working in Pune, as I said, more than 20 years back, or less than, I don't remember exactly now, it must have been 2006 or 7, and Abhay will remember this, that we worked with a particularly, a very enterprising TB control manager who was interested in research, and he himself wanted to work closely with us to start looking at data within his system. And we wrote up that process because we found he was rather exceptional in terms of his dual role as a program manager, but also as somebody who wanted to do research. And often that's a luxury because you don't have the time to do it unless you step out and do a master's degree or something, right? The other thing, so we said evidence on the one hand, but the other thing is setting selection criteria for the use of that evidence. So every time you have a research priority setting process, and even when you're sitting around a small table and saying, okay, we have this, as master students, we have this opportunity to work on a project, or we're affiliated to a specific bigger project, you are still going through a couple of questions in your mind or in your team to set priorities in terms of what you're going to do. And one is whether it's appropriate. Should we do it? Now you might say, what do you mean by appropriate? Is it appropriate to the setting? Is it something that should be done from is it okay from an ethical standpoint, for example, right? Is it something that it fits the interests of the program you're working with? Yeah, so that is a bit different than relevance, because it is more about aligning yourself with your stakeholders, your local stakeholders, or the people that you're working with, your target population. The second point is around relevance. So why are you doing this? What relevance does it have? Now, this is a big point of contention, okay? Why? Because the TB control manager versus the anthropologist are going to say the work has different relevance. Not every piece of research has to have direct applied relevance. So I remember when I first started lecturing years ago on the use of social sciences in public health, at a time when there were not so many anthropologists bridging that gap. And I remember people would always come up to me with, charged up and say, but don't you want to save people? Because they felt that some of the research that we were doing as social scientists didn't necessarily have a direct impact on the lives of people. And I would say, no. What about philosophers? What about economists? I mean, not economists is a bad example, but what about people that want to understand behavior? They want to understand practices. They want to understand how people think about things purely from a theoretical point of view, okay? So again, it's a contentious issue. You might say, as people working in public health, but as soon as you move into the realm of public health, you have to think about, or health more broadly, you've got to think about your research as having application and relevance to improve the situation, improve the health of people. Whereas many social scientists would say they're conducting research not directly to improve the lives of people, but to better understand why people do things the way they do. Yeah? So I think this question of relevance, especially when you're in a mixed disciplinary group, like I showed you the example yesterday, is always going to be a big discussion. Yeah. The next is, can we do it? So that's a kind of a basic question, but you might not think about it, is that sometimes we set a research project and we realize, given the time available, given the skills set, given the appropriateness of how it fits in, I want to do research in clinics and I want to observe consultations, mental health consultations. Is that really feasible, ethically, practically, morally, etc., right? So that's feasibility. And impact is really, again, tied in with relevance. So relevance has to do with, is the topic important and of relevance at a certain given moment in time? And impact is what difference is this research going to make? And again, the stakeholders might be different. Your historian or your anthropologist might say, this is very relevant because this is going to shed light on the historical injustices that have been committed against people who are of a different ethnicity, etc., right? That's the impact for them. Whereas somebody else is going to say, this is going to make a difference because I'm going to be able to show inequities through numbers. I'm going to show you that people who are of X ethnicity are less able to access the system and as a consequence are suffering a higher burden of the condition. Okay? So I'm not going to set these in stone, but always try to think about where am I coming from, what is my interest in this research, and apply that across the board in terms of your questions. So on the right is just a bit of explanation around that. So we're thinking about benefits, issues of affordability, efficacy, effectiveness, equity, coverage. Those are very classic public health or health research questions. We're thinking about issues of the technical, the economic, political, sociocultural aspects when we think about both relevance and feasibility. What are the community concerns? How big is the problem? How severe is it? Does it respond to national health policy and equity focus? And then we're thinking about the issues of acceptability. Some of the questions are outlined there. So I'm going to give you an example. I looked quite long and hard to see if I could find a description of a national level health policy and systems research priority setting exercise. And it wasn't very easy. There are not many good documentations of how people went about this. Ethiopia, as an example, stood out. And I have to say, Ethiopia is interesting. Every year in Antwerp, we get lots of Ethiopians on our health policy and systems research course. So they're really making a concerted effort to bring health policy and systems research into their public health, into their health research curriculum. And they're also involved in quite a lot of innovation in terms of priority setting exercises. So countries like Ethiopia, which has been one of those countries which is known as the good health at low cost countries. I don't know whether that's still true because of the political conflict which is undermining the system, but it is one of the countries that was for quite some time seen as a good example. Obviously face resource scarcity, and basically the less the health budget, the more you need to think about, good criteria for which you're going to use for allocating resources properly. It needs to be critical, it needs to be evidence-based, and so on. In Ethiopia, performance of your key health variables and your progress towards universal health coverage is still low. Lots of challenges, including poor resource allocation, lack of evidence-based decision, weak public-private partnerships, weak intersectoral collaboration, and weak collaborations of academia, so researchers and policymakers. So as in many LMIC, for a long time, HPSR studies were not the primary focus and often led to decisions in the health system that were not based sufficiently in evidence. Yeah. So this is just, we can look at the paper later, but this is what they did, and it's just to illustrate the process. And basically, it's a consensus generating exercise. So they first, in phase 1, they selected participants, and I think they had a mix of participants representing, health stakeholders, but also community stakeholders, I think a number of intersectoral stakeholders as well. And then they had to set and reach consensus on what were going to be the criteria for prioritizing. Yeah. So we had some very general criteria before, which was relevance, acceptability, et cetera, but they took a lot of time to think through the criteria. And then they basically used the building blocks as a framework, and they added on health policy. And they then grouped their stakeholders according to the building blocks. So people who had more expertise on the health workforce, people more on health policy, and on financing. And so within each of the building blocks, they then had to do another exercise where they set priorities within the respective fields of the health system. And then they held workshops to rate, rank, and build consensus on the identified topics. So it's quite a lengthy process, and you might be saying, well, nobody's going to have the time. How would you do this exercise in a short amount of time to reach consensus? So this is a good question, right? It's a practical question. I'm just going to show you the way they set those criteria. So in their case, it's a bit difficult to read, but the first criteria was the impact on health. What is the potential for the research findings to impact population health? Yeah. The second was relevance for policymakers. How much of a priority is this question for implementers and policymakers? The third was workability, likelihood to answer the question using routine or survey data health sets. Okay, so they basically said that our research priorities have to include this criteria of whether the research endeavor is actually feasible within the normal working lives of health program managers. Feasibility, how feasible is it to research it from a cost point of view and an ethical point of view? Availability of evidence and originality, so you don't want to duplicate work that's already been done. And practicability, so is the research result likely to be translated into health interventions or program actions? Okay, so they had to, they set the criteria and then they actually weighted the criteria. And weighting means that some criteria were given more emphasis than others. Oops, sorry. Okay, so that's just an example of national priority setting. And I think now we're going to move to thinking about defining the research problem. Okay, so the priority setting is, as I said, we've talked about at the national level, at institutional levels. You can even think about it, setting, you will see, for example, specific forum that are set up topic-wise. So what are the priorities for looking at gender-based violence, or what are the priorities in HIV prevention? And usually, I think you should all be critical. You should be skeptical. You should say, how did they reach those priorities? What was the exercise that was undertaken? Okay? What criteria are being used? How are those criteria being weighted? Who is being involved in this exercise? So next time you see that, you know, India has set X, Y, Z, or my institution has set these priorities, be critical. I mean, obviously don't risk being thrown out of the institution, but certainly question the processes that lead to some topics being on the agenda and not others, okay? So now we're moving to defining the research problem. So research priorities, we said, they might set the agenda in general, okay? They set the agenda for funders, they set the agenda for institutions, they set the agenda for individuals in some way too. But a strong study begins with a well-defined problem. And usually we can think about two types of problems. So sometimes it's easy to think about a problem as basically something that isn't as it should be. That's the most simple definition, yeah? You have a situation, you know that, you know, your malaria control program is supposed to reach so and so many people, but this isn't the case. So that's the problem, right? Or your new guidelines for XYZ screening are in place, they're accessible, but they're not being used. That's the problem. So it's usually a gap. It's a gap in terms of the policy, which is not reaching the local levels, or it's an implementation failure, or it's inequities, for example, in terms of people's access. But sometimes it's not so easy to define a problem because you just want to fill a knowledge gap. So the problem is just the knowledge gap, yeah? There is not enough known about this issue. That's your problem, okay? So those are two different ways of contrasting. So often a descriptive study, or which is lacking, you know, description, lacking information on the burden, the prevalence, the severity, is also it's a knowledge gap, which can be also seen as a problem. So how is the policy being implemented in practice? So I've instituted a new free maternal health care policy, and I don't know enough about whether it's actually increasing uptake. The problem there is not knowing what impact it's having, right? But if I said I've implemented my free maternal health care policy, I have documented that women from these particular castes are less likely to access the system, that becomes the first type, yeah? So the issue is not as it should be, because we aim to extend universal coverage of these services across the board, but we are seeing in our numbers that so and so many women are not attending, and they all happen to be from more disadvantaged groups. So in health policy and systems research, we're not just talking about practical or operational challenges, but issues that can be researched. So as we said, a knowledge gap, for example, would be, we don't know how private providers are managing diabetes in a low income setting. That's a descriptive gap, yeah? We don't know about their management practices. So your researchable issue is, how do private doctors diagnose and treat diabetes in an underserved area, right? It could be a policy implementation gap, like we said. So the example I just had, despite free maternal health services, poor women are still having low access. Why is the policy failing, or what are the barriers? That's your implementation gap question. Or it could be a systems challenge. So despite government incentives, you know, whatever financial or non-financial incentives to attract people to work in rural and remote areas, there's still a shortage of doctors in rural primary healthcare centers. So your issue is, what factors are influencing doctors' decisions to take up or to reject those rural postings? Okay? So always remember this. It seems like it's a very basic point, but you cannot imagine the number of thesis topics that I review every year which are not problem-driven. So you've got to have a problem to start with, right? Okay, we're going to move into a little exercise. So I'm just wondering whether we should interrupt the recording, but I'm going to just briefly show you something here. So this is a fairly recent article from the UK Guardian, and you can just read it through. Africa's medical system risks collapse in the next few years, warns health leader. Health services in Africa are at risk of collapse in the next few years due to soaring chronic diseases. A senior public health leader has warned. Foreign aid to Africa has been focused on infectious diseases, leaving conditions such as cancer and diabetes to escalate, says this leader. In sub-Saharan Africa, NCDs accounted for 37% of deaths, and so on and so on. They're forecast to become the leading cause of death. Aid is not charity and will inevitably follow donor countries' own interests, etc., etc. Okay, I want you now to tell me what the problem is here that would drive your research. So there's different problems that are looked at. So you can tell me all the problems you spot here, and then we're going to talk about which one leads you to a health policy and systems research question. Okay, anyone? So there's a couple of different things hinted at here, right? So what's the obvious one?
Focus on the infectious diseases, neglecting or under prioritizing the NCDs, causing a rise in deaths caused by NCDs.
Okay, good. So that's all you need to say. So focus on infectious diseases and the neglect of non-communicable diseases. What is another problem, even before that one? Yeah? Go ahead.
Lack of funding for NCDs and like more funding allocated to infectious diseases.
Okay, that's similar, very similar. But even before that, what is the big problem that jumps out? Yeah?
The dependence on foreign aid.
Good. Okay, dependence on foreign aid. But even before that, before the dependence on foreign aid.
The system focuses on mostly on infectious disease. So
Yeah.
if the transformation is there from non-communicable to communicable to NCD, the health system is not ready to take it.
Okay, good. Okay, so you're coming up with similar things, but the first problem that you notice is NCDs are on the rise, right? Descriptive problem. Is that a health systems problem per se? Okay, what would make it a health systems problem? How do you look? Okay, if I tell you NCDs are on the rise in the continent, sub-Saharan Africa, what is your health systems question? Simple question.
That whether the health system is prepared for tackling the increased rise of
Exactly.
NCDs.
Absolutely. Health systems readiness to take on the burden of this rise, right? Or what are the implications of the growing number of NCD cases for the health system? That's a basic question, yeah? But what is a deeper question that is immersed in here? You've noticed, so sorry, you've got two other questions. So one that you raised and one that you raised. So 2 or 3 people mentioned the difference between focus on infectious diseases versus NCD. So what's the question there? What's the problem that leads to the question there? Yeah, go ahead. You mentioned you had that one.
Just thinking out loud, could it be a high prevalence of infectious diseases as well as high prevalence of infectious diseases, existing high prevalence of infectious diseases leading to the health systems focusing on infectious diseases surpassing the NCDs?
Okay.
And then what should be prioritized? Either the increased risk of NCDs or the ongoing infectious diseases.
Say that again, sorry.
it's what to prioritize, whether the increased burden of NCD that we have to address or the ongoing infectious disease which is already creating a lot of morbidities and mortality.
Okay, good, very good. So both of you are on the right track, but just push it a bit further. How would you put it in terms of a nice macro level question?
So are there any policies which are existing which is planned or a roadmap to reduce the NCDs or the infectious disease?
Are there policies to what?
To reduce the how the system will be going to be readiness for the increasing NCDs. So whether the
Okay.
policy is existing or not.
That's not what you said before. Your starting point was infectious disease versus NCDs. So what is the systems question there? Yeah, go ahead.
Maybe about how can resources be allocated to managing both the issues like simultaneously.
Okay. Even more basic is what resources are currently being allocated for infectious versus non-communicable. Okay? So sometimes don't make it too complicated for yourselves. The first thing I'm seeing is a rise of NCDs. What implications do they have for the health system? What do they mean in terms of organizing the service delivery? What initiatives are there to respond to this burden? What is the health workforce doing, et cetera, et cetera? Do they have enough training? Then you have the thing which is implied, which is infectious disease burden coexists with NCDs. So I want to understand at the moment, what is the relative prioritization of funding, health workforce, service delivery models for infectious disease versus NCDs? But another question implicit here, I mean, I'm pushing it a bit far now, could be around to what extent is there any integration of NCD and ID services? Yeah? Okay, but let's come back to this gentleman. He's making a critical point, which you have hinted at, but you haven't yet told me. What is his point? What is he saying here? Read the last paragraph.
Like he is maintaining aid is not a charity and will inevitably follow donor countries' own interests, such as stopping infectious disease. Like some of the donor countries, countries they are giving money, like just because they are interested in infectious disease, that doesn't mean that we need to go for that. It's not a charity. It's out of global interest, global health interest they are giving. That's what he is trying to say that. And also, like in the first statement, it's like there is a soaring chronic diseases. We may need to think why there is an increase in chronic diseases. As they mentioned, it may be NCD or anything. Why there is increase before that may be our research question. Of course we know that Africa is more prone to infectious disease if we look at the history. Maybe the reason the donor countries are more focusing on funding for infectious disease prevention. But that doesn't mean that Africa is not at all having NCDs. There is a growing NCD in Africa also. So the donor countries and the health policy makers of the same country need to think where to allocate the fund. And if we come to say, we can look at the mortality and morbidity. Which disease is it NCD causing more mortality?
Okay, but now you're moving off health systems.
Okay.
Yeah, because if you're measuring burden, prevalence, all that, that's not a health systems question. But what I'm getting at is the fact, which you've already raised, is that his critique is essentially to say that this emphasis on infectious diseases is not just because Africa has so many infectious diseases, it is the global biosecurity concerns which are driving the agenda. So there's a lot of focus on infectious diseases because rich countries are nervous about diseases coming into diseases crossing borders. And so his critique is actually about the fact that within countries, within African countries, the research agenda should be driven by what is very obviously now a growing burden of NCDs, as opposed to towing the line, which is where all the money is put into infectious diseases. Okay? So always be mindful of the fact that even when you read, what I wanted to do is I just wanted to show you that by looking at a simple media article like this is a media cutting, it already can give you a lot of ideas, right? Because you can see, okay, there's a lot of things being touched on. There is something around the impact of NCDs and IDs on the health system. There's something about inequities in terms of resource allocation. And there's something about the macro level donor funding priorities that are being set and how they are skewing local health systems. Okay? So there's already 3 or 4 questions in there. All right? Good. Okay. We're going to stop this session soon, but basically, when you're thinking about problems in health policy and research, you are always trying to address an issue within the health system rather than, as we said, a narrow focus on effectiveness of a clinical intervention or burden of disease. You're thinking about systems levels implications. You're examining how different components of the healthcare system interact and contribute to your issue. And often you are thinking about a specific group of stakeholders. So you often will say, I am thinking about, why stakeholders at the donor level, where are they setting priorities in terms of funding for African health systems? Okay, because you could do some very interesting work on that, right? You could take a critical approach and you could say, how are these agendas being set? Why are we not focusing more on NCDs, etc.? So those are basically 3 things. Okay, now we're going to move into a break. And we are going to do a little research priority setting exercise ourselves. So this is where we will stop the recording and we will move into a half an hour of, I hope, tea, possibly tea or coffee. And then what I'm going to ask you to do is that in your groups, I'm going to ask you to think about health research priorities in India. Okay, I'm not saying health policy and systems research because I think that's too complicated to do right now. But I want you to think about the health research priorities. I want you to create a list of up to, oops, there's a number missing there, up to 7 health research priorities in India. And I want you to make notes on where there is consensus in your group and where there's disagreement and why. And then I want you to think about how is your background or your experiencing influencing what you think should be a priority. Okay? If you had to rank this list, what evidence would you use? What criteria would you set for ranking it? And where would you get the evidence from? Okay, so it's kind of a lot of questions, but actually it's hopefully doable within 20 to 30 minutes. And this is your bonus question. Once you reach consensus on your top health research priorities, how would you start thinking of health policy and systems research priorities within those health topics? Okay, but I think these are the main ones. So we'll stop there. Thank you for your attention so far. And hopefully this will be an interesting exercise that complements what we've just been speaking about.